With that, we'll shift focus now and talk more about uterine fibroids. Uterine fibroids are extremely common. They typically are hypoechoic, well-defined uterine masses, as we see here. But not uncommonly, fibroids can be exophytic, as we see with this posterior fibroid, and they can have areas of necrosis, of calcification, or be pedunculated. And it's these latter findings that lead to many of the pitfalls in diagnosis of fibroids. So because fibroids can be exophytic, they can stick out into the region where one expects the adnexa to be and simulate adnexal pathology. Both of these are examples of how this can happen. We have an exophytic fibroid here, as well as an exophytic fibroid immediately adjacent to the uterus here, both of which on initial scanning were thought to possibly represent adnexal masses. A pedunculated fibroid can mimic an extrauterine mass. Here we have a big solid mass superior to the uterus, which it's not clear if it's originating from the uterus or not, but with further scanning, a bridge of tissue that was very vascular, consistent with a vascular pedicle, could be seen, and this was a pedunculated fibroid. So, because fibroids are so very common and often misinterpreted as representing other pelvic pathology, if one sees a solid pelvic mass, one should first think of a fibroid, even if the mass appears to be adnexal. And then, if one can find both ovaries, that makes a fibroid even more likely, since the ovaries would have been one of the other main organs of origin for a solid pelvic mass. Now, we can misinterpret fibroids as other pathology not only because of them being exophytic or pedunculated, but because of necrosis. This was an interesting example of a patient in the second trimester of pregnancy. You can see the fetal head here, who had a huge complex cystic mass with solid areas of tissue within it. And there was concern that she might have a very complicated ovarian mass. However, fortunately, it turned out that there had been a prior study done on the patient during the first trimester of pregnancy. You can see the embryonic crown rump length here, and at that time the mass had an entirely different appearance. It was completely solid in appearance and had some areas of shadowing from it, and this mass was simply due to a fibroid that had infarcted and degenerated and become very necrotic. Peripheral calcification is a not uncommon pattern of calcification of fibroids, and when it's seen, it has the potential to be mistaken for a fetal head. So here we have a rounded rim calcified structure that on first glance was thought to possibly represent a fetal head, but in the setting of a live pregnancy, this is usually quite easy to resolve. With further scanning, the normal appearing fetal head is seen, and it's clear that this is a fibroid. Where this can be potentially problematic, though, is in the patient who's had a recent miscarriage or an abortion and is referred to rule out retained products. Because as in this case, the initial impression can be, oh my God, they left the fetal head. However, this is simply a rim calcified fibroid, which is much, much more common than retained fetal head following a miscarriage or an abortion. In fact, until recently, I thought the latter virtually never was seen, and then we saw this case. This is a patient who'd had an abortion and was referred to rule out retained products, and you can see echogenic material in the uterus here, as well as a rim calcified structure in the cervix. On further assessment of the rim calcified structure, you can actually see that it has orbits as well. And in fact, in this case, they had left the fetal head, and the patient delivered the fetal head as well as additional products of conception shortly thereafter in the emergency room. Other processes that can be mistaken for fibroids not uncommonly include a retroflexed uterus. The retroflexed uterus is shown here. The posterior extension of the retroflexed uterus looks like it could be a hypoechoic fibroid because its orientation is such that it makes it somewhat tricky to show the endometrial stripe, which is located parallel to the ultrasound beam. But if one simply adjusts the transducer laterally and angles in, trying to show the endometrial stripe, you can see that the stripe is continuous, and this is simply a retroflexed uterus. This is not uncommon. Here's another example. We see the uterus in transverse and longitudinal projection here, and then we see a hypoechoic structure posterior to it, which it's not at all clear on these initial images that this would be a fibroid, and was initially thought that this would be a retroflexed uterus, and this was initially thought to represent a fibroid. Now, this pitfall only occurs at transabdominal ultrasound because of how the endometrial stripe is oriented again relative to the ultrasound beam. And here we can see the endometrial stripe coming down into what was initially thought to be a fibroid and isn't. This is a retroflexed uterus. This can be confirmed with endovaginal ultrasound, which will show in a retroflexed or a retroverted uterus that the uterus points to the right side of the image. An anti-positioned uterus would point to the left side of the image. With that, I want to talk a little bit about uterine orientation. This is because usually if the uterus appears to be retroflexed or retropositioned at transabdominal ultrasound, it would be expected typically to also appear to be retroflexed or retropositioned at endovaginal ultrasound. This usually, but not always, holds true though. One way in which this can happen, that on one technique, one approach, the uterus is antepositioned, and on the other approach, it's retropositioned, is due to different degrees of filling of the bladder. Here you can see with this patient's bladder very full, the uterus is ever so slightly antepositioned. On a different study performed the same year, though, the bladder was less full. We can see the bladder here, and now you can see that the uterus is actually retroflexed. And at endovaginal ultrasound on this patient, when the bladder was totally empty, again, the uterus was retroflexed. So the different degrees of bladder distension, if the uterus is relatively flexible, can cause the uterus to look either antepositioned on one study and retropositioned on the other study. And it's not just degrees of bladder distension that can do this. On an endovaginal ultrasound, the uterus can look both retroflexed, as it does here, and anteflexed, as it does here, during the course of a single examination, and this is thought to be due to transducer pressure. In this particular patient, the uterus was flopping into both positions multiple different times, depending on how the transducer was oriented and presumably on how the pressure was affecting its orientation. But this is relatively uncommon. In most cases, the uterus will stay one way, either retropositioned or antepositioned throughout the study. Another process that can be mistaken for a fibroid is shown here and includes uterine fusion variants. Here we have the uterus and the endometrial stripe, and off to the left side on this endovaginal image, we have a rounded, solid structure that looks like it could be a fibroid. However, with further imaging, you can see there are endometrial stripes in both of these studies, both of these structures, because this is not a fibroid on the left, but rather the patient has a didelphys uterus. Now, interestingly, once that was realized on the transverse scan planes, and an attempt was made to show both uteruses at endovaginal ultrasound, it turned out that the uterus on the right was antepositioned and the uterus on the left was retropositioned. So because fibroids can mimic so many other things and be mimicked by so many other things, it's useful to have some clues that can help one make positive diagnosis of a fibroid. And one of these clues is to see sharp shadows at regular intervals, like we see here. Sometimes shadows from fibroids are due to calcifications, but this particular pattern is not due to calcifications because, as you can see, these are not coming from echogenic lead points. Calcifications would have echogenic lead points. In fact, this is another example of this shadowing pattern from a fibroid, and the shadowing is thought to be due to refraction or phase cancellation at transition zones between different materials within the fibroid. Now, this shadowing pattern, the recurrent shadowing pattern, is very typical of fibroids, but it's not completely specific, and probably the most common exception is to see this shadowing pattern in the setting of adenomyosis. This is a patient who has the shadowing pattern but does not have a focal mass. Rather, the pattern is diffuse, the abnormality in the uterus is diffuse, and when you don't see the shadows coming from a focal mass, consider the possibility of adenomyosis.